audible now? Yeah. Thank you.
Yes.
Thank you, Chairperson, sir. And I thank ESI, Dr. Shaptarshi, Dr. Shaila for considering me for this onerous job of addressing particularly a knowledgeable, erudite audience of the endocrine and ophthalmology fraternity with a rather difficult topic, a vision in endocrinology. Trying to prepare the lecture, what I found that visual problems in endocrinology is not equal to diabetic retinopathy and cataract, which of course are the two most common visual problems that we encounter in endocrine practice. But probably every endocrine disease, directly or indirectly, may affect vision. But since diabetes is the most common and the most important cause of visual morbidity, if that is untreated or uncared for, I will devote a significant amount of time to diabetic eye disease. Now, what can cause visual loss in diabetes? We all know cataract, glaucoma, diabetic macular edema, diabetic retinopathy, especially the complications of diabetic retinopathy like vitreous hemorrhage and retinal detachment. Even severe proliferative diabetic retinopathy may not lead to any visual loss. And, retinal venous occlusion, arterial occlusion, branch vein occlusion, etc. are also more common in a patient with diabetes as compared to the general population, simply because diabetes is a pro-thrombotic state. And one of the most serious complications of, I think that has been in the quiz, probably now I can give out the answer, because I think they have all given the answer. One of the serious complications of diabetic retinopathy is rubeosis iridis, which can cause neovascular glaucoma. So cataract is 2 to 5 times more common in patients with diabetes than without. And diabetic cataract may be of 3 types. The accelerated senile cataract that is common. We have patients who are having type 2 diabetes develop senile cataract on an average a decade earlier than their non-diabetic counterparts. Especially in type 1 diabetes, periods of poor glycemic control are associated with snowflake cataract, which may be partially reversible with good glycemic control, and also there may be posterior subcapsular cataract. And after certain surgeries, notably cataract extraction, complications of cataract extraction, though generally are rare in good hands these days, but still these complications are more common in patients with diabetes, like pseudophakic cystoid macular edema or certain deterioration in the retinopathy grades following ocular surgery. Now, very briefly, the etiopathogenesis of diabetic cataract. Here, the polyol pathway is invoked. There is increased activity of aldose reductase because of the hyperglycemia, which leads to activation of the polyol pathway, and sorbitol accumulates inside the lens, which actually contributes to opacification of the lens. At the same time, there is formation of advanced glycation end products. So that these are the two main things, that is the activation of the polyol pathway and formation of advanced glycation end products, which actually change the quality and nature of the lens proteins, leading to opacification. Glaucoma. Now, there has been an association between type 2 diabetes and primary open angle glaucoma, meaning that patients with diabetes are more prone to develop open angle glaucoma compared to their non-diabetic counterparts. But whether there is any direct causal relation can be debated hours on end. Again, in glaucoma, the deranged metabolic milieu of diabetes is responsible for this increase in the intraocular pressure. The most important being hyperglycemia of the aqueous humor leads to increased synthesis and accumulation of fibronectin in the trabecular meshwork. This depletes the trabecular meshwork cells and impairs drainage of aqueous, leading to increase in the intraocular tension. That apart, vascular dysregulation, oxidative stress, inflammation, reactive gliosis, formation of advanced glycation end products, as well as the polyol pathway have been invoked in the causation of glaucoma as in other etiology of diabetic retinopathy. Diabetic retinopathy is, I think, the most discussed ocular complication of diabetes. It can occur in up to 50 to 60% patients of type 2 diabetes, and depending upon the duration, can occur in up to 90% in patients of type 1 diabetes. The risk factors are many, apart from hyperglycemia. So hyperglycemia, chronic hyperglycemia, is not the sole risk factor for diabetic retinopathy. Uncontrolled hypertension, dyslipidemia, duration of diabetes itself, and as I have said, cataract surgery can worsen, it can lead to the complications of cataract surgery, which are more manifest in patients with diabetes than without, nephropathy, pregnancy and puberty, and interestingly, attempts at rapid control of glycemia can temporarily worsen retinopathy grades, as was seen in the DCCT and maybe also in the ETDRS. So, but as I would like to say, all diabetic retinopathies will not cause visual abnormalities as in mild non-proliferative diabetic retinopathy or even severe proliferative diabetic retinopathy, that is neovascularization on the disc even may not cause visual abnormality, only when this leads to a vitreous, a tractional retinal detachment or a vitreous hemorrhage or a preretinal hemorrhage, then there may be sudden acute loss of vision. So this is a message that we have to keep in mind as endocrinologists, that examination of the eyes, of the fundus, whether by the endocrinologist himself or herself, or with the help of an ophthalmologist colleague, is must on a periodic basis, even if the patient doesn't volunteer any visual symptoms. On the other hand, the diabetic macular edema of certain severity can cause visual impairment, and this has been classified as mild, moderate, and severe. And I think OCT is an important diagnostic tool to pick up a grade diabetic macular edema. So again, this is a busy slide, but actually summarizes the proposed hypothesis behind the causation of diabetic retinopathy. Two things are very important. The starting event is probably a retinal ischemia. The starting or the triggering effect, a triggering event of the retinal vascular abnormalities is microischemia. Therefore, when you treat what is the essence of treatment of panretinal photocoagulation in proliferative diabetic retinopathy? It is to decrease the panretinal photocoagulation is done to decrease the retinal ischemic burden so that the rest of the retina is salvaged. So the triggering point may be a retinal ischemia, but then oxidative stress. And as I pointed out, formation of glycation end products and advanced glycation end products, derangements in the polyol pathway leading to accumulation of sorbitol, which is hygroscopic and mainly affects the lens, and formation of reactive oxygen species, endothelial dysfunction, increase in vascular permeability, all come into play, not to forget the role of growth factors like vascular endothelial derived growth factors, growth hormone, and IGF-1, which is why one of the important therapies of these days is VEGF antagonism in the management of diabetic macular edema and proliferative diabetic retinopathy. Apart from laser photocoagulation, mainly what does laser photocoagulation do? In panretinal photocoagulation, they are decreasing the total retinal ischemic burden. And what do VEGF antagonism do? They actually take away the deleterious effects of these growth promoting factors. Now, neovascular glaucoma or rubeosis iridis, that is neovascularization of the iris, and invariably this accompanies neovascularization of the retina in a very florid, severe case of diabetic retinopathy, and this can block the drainage of the angle and can lead to severe form of angle closure glaucoma, new blood vessels obstructing the aqueous humor outflow, and secondary to posterior segment ischemia. And the onset is generally correlated with poor glycemic control. And I think this is one of the severest and vision-threatening complications of diabetic retinopathy. Apart from this, certain drugs used in the treatment of diabetes can cause visual abnormalities. Notably, pioglitazone or thiazolidinedione can actually aggravate macular edema. I still remember of one patient who comes to me for regular follow-up, whose diabetes, who actually had diabetes, was prescribed pioglitazone by some physician, and he attended the ophthalmologist with a sudden dimness of vision, visual acuity, and the ophthalmologist found florid macular edema, but no features of diabetic retinopathy in the periphery, and she referred the patient immediately to me. I withdrew the pioglitazone, and the ophthalmologist, of course, did whatever necessary ophthalmological treatment, and his vision improved dramatically, and now he is doing fine. Well, hydroxychloroquine is more used probably these days for COVID-19 than for diabetes, but in India, it is an approved medication for the management of diabetes, if not controlled on 2 oral agents that can cause bullseye maculopathy, which I think the ophthalmologists know much better than us, but this has also to be kept in mind. And as I have said, rapid attempt of glycemic control, especially with insulin, during pregnancy or even outside of pregnancy, can temporarily worsen retinopathy grades. So much so, the dictum is that if a patient with diabetes having florid retinopathy wants to become pregnant, one should first stabilize the retinopathy by way of intravitreal injections of bevacizumab or something like that, or laser photocoagulation, stabilize the process of retinopathy, and then ask the patient to become pregnant, whereby you need to tightly control the hyperglycemia with insulin. Now we move on to other endocrine conditions. Let's start with pituitary. Now, pituitary adenomas, the macroadenomas, can compress the optic chiasma and the optic tract because of the anatomical proximity and cause visual abnormalities. So, visual acuity problems can occur in up to 15 to 85% patients of pituitary adenoma, but visual field abnormalities are more common, may occur in even up to 100% patient cases in certain cities, but that's 30 to 100%, and there may be other unspecified visual complaints. And following successful treatment, the visual recovery in the visual defect is not always 100%. It may even be less than in 50% cases. And, an off-targeted radiotherapy or a mishandling of the optic apparatus during a transsphenoidal surgery can also add to the visual impairment. So microadenomas expectedly do not impact vision. Small macroadenomas, less than 2 centimeters in diameter and which are strictly intracellular, are likely to cause no visual problems. But it is the larger tumors that can cause or that usually cause visual abnormalities. Non-functioning pituitary tumor is the cavernous subtype which cause visual problems because those who are functioning, they are detected probably much early, like a prolactinoma in female, and so they do not grow to that extent to cause visual problem. They are detected and treated much earlier than that. But a prolactinoma in men, however rare it may be, can cause visual abnormalities. What's the pathophysiology of visual defects? A little bit into the anatomy. The compression causing direct disruption of the axonal conduction, impairment of axonal flow, demyelination, and ischemia are the main causes of this visual impairment. Initially they may be reversible, but if they are long-standing, the visual changes may become permanent, and even after surgery, there may be incomplete improvement. And there may be cranial nerve palsies also, especially if the tumor invades the cavernous sinus and or compresses, which can also add to the visual problem. Now, this this is a well-known diagram. So the optic nerve may be compressed, leading to unilateral blindness. The optic chiasma may be compressed, leading to the typical bitemporal hemianopia. If the optic tract is jeopardized, there may be homonymous hemianopia, so on and so forth. This we know. And then the question comes whether it's a prefixed chiasma or a postfixed chiasma. In about 10 to 20% cases, the chiasma may be prefixed, that is placed anteriorly, and if a tumor growing from below will compress the optic radiation, whereas and leading to contralateral hemianopia. And if it is directly above the chiasm, there will be the typical bitemporal hemianopia. And if it is post-fixed, then there would be unilateral monocular visual deficit. This is another way to show. I think there was a very good question on Wilbrand's knee issue. So I think most of you have answered it well. Compression of the Wilbrand knee will lead to ipsilateral junctional scotoma with superotemporal hemianopia. And what is Wilbrand knee? Wilbrand knee is actually, you see, this is the Wilbrand knee which is going into from one optic tract, optic nerve through the optic chiasma, making a detour around the other optic nerve and coming out. So this is an interesting thing. Then pituitary apoplexy can lead to sudden onset visual impairment and headache, as we all know, and even lead to blindness in up to 1/3 of cases, along with ocular nerve palsies. Apart from that, acromegaly itself can cause visual impairment by increasing the corneal thickness, by causing pigmentary retinal degeneration. There may be angioid streaks. Again, there was a beautiful question on angioid streaks. Angioid streaks can occur in Paget's disease, pseudoxanthoma elasticum, Ehlers-Danlos syndrome, diabetes. Diabetes may be associated with angioid streaks, lead poisoning, hypercalcemia, and also acromegaly. There may be rarely melanocytic tumors of the choroid. There may be enlargement of the extraocular muscles and increase in orbital fat, leading to proptosis, and there may be ophthalmoplegia too. But we rarely do not see these things that commonly in acromegaly, but this can occur, and these have been reported in literature. What is more important, probably the tumor compressing the optic chiasm, optic tract, and so on. Another very interesting ophthalmic abnormality that is an iatrogenic one is a radiation-induced optic neuropathy. This can lead to a sudden painless monocular visual loss, preceded in some instances by certain monocular or binocular visual impairment that had been transient. Further deterioration can progress over weeks, and if it starts as a monoocular visual loss, that can end up in a binocular visual impairment. And the loss of visual acuity is variable. What are the risk factors? Young age, the treatment modality, and the dose of radiotherapy. So what treatment means, what type of radiation you are using, that is also important, and what is the dose of that radiation, both are important. Another very common abnormality that we encountered in endocrine workup is a septo-optic dysplasia, of which hypopituitarism is a part. A classic triad consists of optic nerve hypoplasia, pituitary hormone abnormalities, mainly commonly panhypopituitarism, and midline defects like agenesis of septum pellucidum and or calpus callosum. You see, this is a spectrum disorder. Patients may have isolated growth hormone deficiency to multiple pituitary hormone deficiency. On the other hand, so far as visual impairment is concerned, the patient may have unilateral asymptomatic optic nerve hypoplasia to complete blindness. So this is radiologic, how it looks like. That is, there is, you see, anterior pituitary hypoplasia and absent infundibulum with bilateral optic nerve hypoplasia. The posterior pituitary is ectopic, and also there is absence of septum pellucidum. Now we come to thyroid. Most important is thyroid-associated orbitopathy. About 25 to 30% patients of Graves' disease will develop Graves' orbitopathy. And you should remember that Graves' orbitopathy can be associated with thyrotoxicosis, can be associated with euthyroidism, spontaneous euthyroidism. Only there may be orbitopathy with no thyroid functional abnormality, and also rarely with hypothyroidism. Second, though commonest is association with thyrotoxicosis. Second, in Graves' disease, and about 5% of patients, the orbitopathy may antedate Graves' hyperthyroidism. In a majority, 60 to 80% cases, Graves' hyperthyroidism and orbitopathy occur together, and in some around 10 to 20% cases, Graves' orbitopathy may post-date Graves' hyperthyroidism in appearance. And as you know, though both have a similar mechanism of action and mechanism of etiology, which I'll come to just in the next slide, but these two diseases can run an independent course. And another very important vision-threatening complication, apart from exposure keratitis due to severe proptosis, is a dysthyroid optic neuropathy. So there may be many visual abnormalities in dysthyroid optic neuropathy, but the visual acuity is quite often affected. You see, reduced color vision was seen in about 80% cases of definite dysthyroid optic neuropathy. Visual acuity also to similar to the tune of 80%. Optic disc swelling, optic pallor, so these are other things. But so visual dysthyroid optic neuropathy is associated with some degree of visual impairment in a large percentage of cases. What are the risk factors for thyroid-associated orbitopathy? It is more frequent in women, but minded severity is more in men. Though Graves' orbitopathy is more common in women, should it occur, it runs a more severe course in men. It is more frequent in Caucasians than in Asians. Age, duration, longer the duration of Graves' disease, the higher risk of tau. But having said that, I have told the two diseases may run an independent course. Smoking is a definite positive risk factor for aggravation of thyroid-associated orbitopathy. Hypothyroidism, especially iatrogenic hypothyroidism following radioiodine therapy or even surgical ablation, is an important risk factor for aggravation of thyroid-associated orbitopathy, and also radioiodine therapy itself. Therefore, in severe cases of thyroid-associated orbitopathy, radioiodine therapy is contraindicated. So this is, in short, the mechanism how the TSH receptor antibodies help in the development of thyroid-associated orbitopathy. There is actually a crosstalk between the TSH receptor antibody acting through its receptor and IGF-1 acting via the IGF-1 receptor in the orbital fibroblast. It leads to formation and deposition of adipose tissue, that is adipogenesis, leads to accumulation of hyaluronic acid, which is actually hydrophilic, and this leads to increase in the volume of the muscles, increase in the volume of the orbit, and this leads to proptosis. And if there is less proptosis, those patients are more at risk of developing dysthyroid optic neuropathy. Eventually, this inflammation may settle down on its own, leading to fibrosis when the disease becomes inactive. So this is one muscle index computation. I think this actually falls in the purview of the radiologists, who should compute this muscle index and give an idea of how severe the muscle thickening is in a particular case of thyroid-associated orbitopathy with the help of a CT scan of the orbit. If the muscle index is more than 70%, there is a high chance of dysthyroid optic neuropathy being present, because it has been seen that more than two-thirds cases of dysthyroid optic neuropathy have a muscle thickness or a muscle index more than 70%, whereas if the muscle index is less than 50%, then likelihood of having dysthyroid optic neuropathy is less. Now we come to hypothyroidism. We are more concerned about thyroid eye disease in association with, that is tau, that is thyroid associated orbitopathy in association with hyperthyroidism, euthyroidism, or hypothyroidism, spontaneous or iatrogenic. But that apart from thyroid associated orbitopathy, hypothyroidism per se is associated with greater incidences of cataract, xerophthalmia, corneal dystrophy, and keratoconus. This is because thyroxine is required for tear production, corneal hydration, and transparency, of course, in animal studies. Therefore, severe, long-standing, untreated primary hypothyroidism can lead to a dry eye. Now we come to gonads. There are many syndromes which may be associated with certain ocular manifestations, like Kalman syndrome may be associated with optic atrophy. Klinefelter syndrome may be associated with coloboma of the iris, microphthalmia. Everything may not lead to visual abnormality, though strabismus and in 49 XXXY myopia is more common. Similarly, Turner syndrome may be associated with a host of ophthalmic abnormalities. Of course, not everything will lead to visual impairment. Amblyopia will lead to visual impairment, but a partial ptosis or a mild strabismus will not. There may be an epicanthic fold, there may be hypermetropia, and rarely keratoconus, glaucoma, cataracts, and retinal detachment may be associated with Turner syndrome. Then we come to some other syndromes like the Bardet-Biedl syndrome, which it's not a very rare disease associated with hypogonadism, central hypogonadism, polydactyly, and the retinal changes may be retinitis pigmentosa, that is pigmentary retinal degeneration. Though this is atypical retinitis pigmentosa, I think our ophthalmologist chairperson can enlighten us how to differentiate between typical retinitis pigmentosa and other pigmentary retinal disorders that we get to see in syndromes like Bardet-Biedl syndrome or the Cancer syndrome. Similarly, Prader-Willi syndrome, which is typically characterized by obesity, infantile hypotonia, and hypogonadism, short stature, can be associated with strabismus, refractive errors, even amblyopia, hypopigmentation of the iris and choroid, congenital ocular fibrosis, and ectropion uvea. Now we come to bone. In hyperparathyroidism, there may be ectopic calcification, both in hyperparathyroidism as well as hypoparathyroidism because of alteration in the calcium phosphate ratio. This can lead to choroidal calcification, retinal calcification, calcification of the eyelids, recurrent conjunctivitis. But what can actually lead to visual impairment is the band keratopathy. So this is also because of deposition of calcium in the cornea. Band keratopathy can lead to visual impairment, and treating the underlying cause of hypercalcemia almost always yields resolution of ocular symptoms unless it's very severe. Similarly, hypoparathyroidism may be associated with periorbital tetany, blepharospasm, cataract formation. Again, many of them may not lead to major visual impairment, but again, corneal opacities can be there. Nanophthalmos is associated with Kenny-Caffey syndrome, and papilledemia is also not uncommon. And with hypoparathyroidism, especially following surgery, there may be rapidly progressive corneal opacity. McCune-Albright syndrome, which we know is characterized by fibrous dysplasia, cafe spots, and a gain of function mutation in the GS alpha subunit of the receptor, can be associated with visual field defects, and there may be optic nerve compression leading to optic atrophy and visual impairment. Similarly, Paget's disease is one of the causes of proptosis and optic neuropathy, and this also has been associated with angioid streaks and choroidal neovascularization. Osteogenesis imperfecta can be associated with corneal opacities, myopia, astigmatism, optic atrophy, and also the blue sclera that we typically know of or associate with. In osteopetrosis, also because of the local effect, the mechanical factors impaired optic nerve myelination. This will result in optic atrophy, ptosis, strabismus, proptosis, and extraocular muscle palsy, as well as retinal degeneration. So next we come to adrenals. Well, glucocorticoid excess, whether it's an endogenous glucocorticoid or exogenous glucocorticoid, has been shown to be associated with two things, glaucoma and cataracts. So glaucoma is more common with exogenous glucocorticoids because they alter the trabecular meshwork morphology and reduces aqueous humor outflow, thereby elevating the intraocular pressure. And topical glucocorticoids are mostly incriminated in causing precipitating or aggravating glaucoma, though even systemic glucocorticoids, as in anecdotal case reports, have been shown to do the same. Cataract is again more common in exogenous Cushing syndrome. Typically, this is a posterior subcapsular cataract, and this can again occur more with topical glucocorticoids being used for a long time, but can also occur, as I will show you, with systemic glucocorticoids too. Cushing syndrome is one of the causes of proptosis, probably because of retroorbital deposition of fat, and central serous chorioretinopathy can also be associated with increased glucocorticoids. So as I was saying, route of administration leading to steroid-induced glaucoma. Not only eye drops and eye ointments, not only subterranean injections or retrobulbar injections, but oral, topical skin injections, and inhalational steroids also can lead to increase in intraocular tension and precipitate glaucoma. Adrenal insufficiency, Addison's disease, or acute withdrawal of steroids can lead to papilledema. Adrenoleukodystrophy, though rare, has been typically known to be associated with optic atrophy, with impairment in visual acuity and visual fields. Then Algrove syndrome or AAA syndrome, which is characterized by Addison's disease, alacremia, and achalasia cardia. So because of alacremia, there can be keratoconjunctivitis sicca, even corneal melting. There may be lacrimal gland atrophy. That's actually the cause of alacremia. And there may be pupillary abnormalities too. Ultimately, can even lead to amblyopia and optic atrophy. Polyglandular autoimmune syndrome type 1 also may be associated with a host of ocular manifestations. You know, APS1, the major components are hypoparathyroidism, primary adrenal insufficiency, and mucocutaneous candidiasis. The severity of ocular manifestations is not correlated with the systemic manifestations. Though chronic keratitis occurring in about a quarter of patients is the commonest and most typical ocular abnormality, other heterogeneous ocular abnormalities can occur, and this is because the corneal affection is probably because of an autoimmune attack against the corneal epithelium. There is a poor genotype-phenotype correlation, and the prognosis is also poor. So apart from keratopathy, there may be other ocular manifestations, which of course are rarer than keratopathy. That may be retinopathy, pigmentary, including a pigmentary retinopathy, and others like a dry eye, cataract, erythrocyclitis, retinal detachment, and optic atrophy. So this is actually the example of a keratopathy in APS type 1, and this is even after the corneal transplant. The transplanted cornea also have become opacified. Pheochromocytoma can be associated with hypertensive retinopathy as a complication of untreated hypertension, but the von Hippel-Lindau syndrome has been associated with typically retinal hemangioblastoma, which is usually present bilaterally. And the proposed mechanism, exact mechanism is not known, but one proposed mechanism is increased expression of certain growth factors like vascular endothelium-derived growth factors, platelet-derived growth factor, and transforming growth factor alpha because of a lack of protein, that is PVHL, that leads to this tumor regenesis. In men to be may be associated with prominent corneal nerves, eyelid and conjunctival neuromas, because a huge neuroma simply by pressure effect can cause visual abnormalities, and rarely there may be choroidal metastasis from a medullary thyroid carcinoma. Neurofibromatosis again may be associated with a host of ocular manifestations like the leash nodules, which are nothing but hematomas in the iris, may be associated with the glaucoma, and most important is an optic nerve glioma. I think we had an excellent quiz question on optic nerve glioma. Mind it, only 20 to 30% are symptomatic. So optic nerve glioma may be asymptomatic too, can present with planeless proptosis with or without visual impairment. So 15 to 40% of children with neurofibromatosis 1 have optic nerve glioma. Some of these lesions are asymptomatic, that is, not all are symptomatic. Bilateral optic nerve gliomas are almost pathognomonic for neurofibromatosis 1. And unilateral decreased visual acuity with relative afferent pupillary defect may occur. So leash nodules, we have.
Dr. Nilangan, I'm very sorry to interrupt. We have.
Okay, so I'll winding up in 1 minute.
Yeah.
It's
a lovely, so much of learning, but I wish I had more time. That's all. So sorry.
Benign hematomas and other ocular endocrine syndromes that I think I have alluded to: cancer, Didmouth syndrome, Usher, Cockayne, and Werner syndromes. To conclude, therefore, though our bread and butter would be diabetic retinopathy and cataract and thyroid-associated orbitopathy, as well as a pituitary, hypothalamo-pituitary SOL causing visual problems, we have to keep in mind that virtually any endocrine disease can directly or indirectly impact vision, and we must have a high index of suspicion. And needless to say, we need to have a collaborative clinical approach for uncovering these visual problems and addressing them where possible. Thank you. Thank you for the opportunity.